Good morning, everyone. So I'm a little more on fumes, so I may not be as bubbly as I normally am because this is my sixth day of conferences. So excuse that if I'm not, but I'll try to make sure it's informative, but yet not too dreary. So. All right, well, I have the pleasure of actually being able to share with you a little bit more information about what we did actually on a town hall at the Radiological Society of North America. Their conferences are this same week. So I started out my travel on Sunday morning and had meetings all day Sunday. On Monday, we had a town hall. And so what I'm going to be sharing with you is what we announced there, a little bit more about what that means, so you're aware, because there's some exciting things. Image exchange will hopefully be something that we'll start seeing with support from the 3 early adopters by sometime 2020. We don't have exact timelines and dates yet, but wanted to share some of that. So we have been partnering with the Radiological Society of North America as the Sequoia project since 2014. They actually asked us to start running a testing program for them that we call the RSNA Image Share Validation Program. It's equivalent to the certification requirements that are done within the European realm. So it's the same test tools, the same test cases that's done over there for their certification. But we've been doing that for a while, and RSNA, being the member organization that they are with all the radiologists, they've actually been asked to try to help deploy and enable the image exchange. So we've continued our partnership through that time, and with my contacts from Sequoia, I worked with Dave, and we actually kind of jump-started the image exchange. So I'll give you a little background of that. So really, why aren't we exchanging images today? There's a lot of different reasons. Most of them are because point-to-point interfaces are expensive. You don't want to have individual business associate agreements with each entity that you exchange with. That's just not scalable. Really, there was never a focus from ONC even to try to enable images. So everybody does the bare minimum, but we all know that images are a very important diagnostic tool for the providers or clinicians to help take care of their patients. And as being a caregiver myself, I have to help my father, who does a lot of his health care through the VA, make sure, okay, Papa, you have to make sure to get that disc, and we've got to make sure that I get a copy of it so that when you give it to the doctor, we don't have to go get another one. The VA at least doesn't charge for those discs, but most people have to pay $25 or more to get that disc, and they just don't think about that. They don't think about how that image is something that they may want to keep. If it's a chronic illness or mammography, they want historical images. So a lot of that is just reasons unknown, but I mean, the architecture that we have for Carequality can enable the same image exchange just with a different payload known as a DICOM package. So there's lots of different reasons. I'm not going to read those to you, but just kind of setting the tone of why do we really want to do it. It's the right thing to do for the patient, the providers, to make the most informed decisions for the care that you're going to receive. Really, why again is image exchange right now, and this is coming from Dr. David Mendelsohn, so it's a quote from him at the top there. Up to 20% of imaging exams may be inappropriate. And it's because, and inappropriate can mean different things. It may be that that clinician doesn't know that you just had a chest x-ray done 2 weeks ago. Because you didn't tell them that. It might be that you're in an emergency situation and they need to have something, but there's something that they could have referenced from something before. So there's lots of reasons for that inappropriate, what I would call request and so forth. But if you really think about it, how it impacts the patient has more radiation exposure and all of that. The costs are the biggest thing, though, because costs are so extraordinarily high with healthcare anyway here. Imaging makes up a huge amount of that. So we want to make sure that we think about what's right for the patient, but we also do what's right for their care and their care delivery. A lot of times it's just that data is not accessible. Even if they know that you've had an image done, they can't get to it. They usually can't even get to the radiology report yet. So it's one of those things that you have to think about how this will really impact care. We're hoping that this will be, as Dr. Mendelson says, a game changer. So there's two ways that image exchange is happening. So I'm not saying that it's never happening, it's just not happening ubiquitously. It needs to happen everywhere, to all different specialties. Cardiology is another specialty that has imaging that needs to be exchanged and shared, not just radiology in general, but cardiology. A lot of times big orthopedic organizations will have their own imaging systems and things like that. So making sure all of those different image acquisition sites, whether it's in a hospital or in some other department or facility or practice or wherever, making sure that all of those are available. So that's our goal. But today these are exchanged really either on the disc. EMRs do get the results from radiology exams. A lot of times those are exchanged, but really it's a light process. It's not a lot of data because truly the PAC systems that acquire those images don't send a lot of information with the image. They don't have a lot of demographics even. So there are going to be some things that these imaging vendors have to make sure that they tighten up and make more robust, things like patient demographics, so that they can do the matching that is required. So we are going to be making some of these imaging vendors raise the bar a bit so that we can start enabling that. So I'm very encouraged that that's going to be happening. So exchange is happening that way, but really view only is the biggest reason or way that images are shared today. The DICOM payload very rarely is exchanged. That sits in the source and it sits there. And if you have an integration to that source, great. But if you don't, well, it's that disk. And that's really the only other way that that's exchanged. A lot of times it requires some sort of PACS viewer if you're going to have diagnostic quality images and so forth, but most of the time physicians don't need those diagnostic images. They just need to have the basics. Even if they're interacting with the patient, saying, okay, this mass that you have here, this is what I'm looking at, just helping educate the patient on what is wrong with them, what's happening in their life at this time. But we really need to empower that, a greater way to deliver, easier to allow for comparisons, for prep for surgeries. We need to start making this so that, a lot of times delays when you have a procedure is because they need to wait a week or two to get your image and that result back. What if you need that surgery and that could make a difference having it a week sooner? In some instances, those are things that need to be impacted. So thinking about image exchange and hoping to make that better, to not just having view only when it can be something more robust, or even just making it so that you do have that view only at the right place at the right time in much more robust locations. There's different methods. So the network-based clinical sharing, there's again the different methods that are including the local hospitals. There's a greater growth of bigger hospital systems where they've all consolidated, so integrated delivery networks that are very large. There's really the exchange that's happening today, again, peer-to-peer, very basic. In New York, as one of the states, I don't know if Valerie Gray is still here or not, but New York has a pretty robust image exchange, but that's because they rolled it out with one vendor platform, and we want to make sure that that one vendor works with all the others that exist already in all the different hospitals. So there are some states that are a bit more progressive, but we really want to encourage the standards-based approach so that everybody builds that one interface. Some of these proprietary point-to-points are working. I'm not going to say that there is no image exchange again, but they need to reduce those costs by reducing those point-to-point instances. The stakeholders that are involved in trying to move this forward toward the exchange are the standard development organizations. So integrating the healthcare enterprise, IHE started in the radiology domain. A bunch of radiologists got together and said, look, I'm tired of having to send an ADT system to or an ADT message to your scheduling system, which doesn't talk to the RIS easily without another interface, and then the RIS has to have another interface to the PACS. That was 3 interfaces, and they're saying this is stupid. So they actually started this back in '98, and IHE was born to solve those workflow problems. And that first profile was something called scheduled workflow to address, here's how you get that ADT to the scheduling. Here's how that scheduling information gets transferred to the risk system for all of the billing and reporting and stuff that has to happen later, and then to the PACS as well. So they started improving that. IHE does reference the DICOM standards, the diagnostic imaging standards from DICOM, as well as HL7 standards to enable a lot of this work. But what I'll be talking to you today about is more focused on the whole platform technology that Carequality already has enabled, the cross-community access, XCA, -I for imaging. So it's the same transactions, it just has a different payload. It's not a CDA document, it's a DICOM package. So that's what we're looking at doing. The stakeholders are also those patients and caregivers. I've already kind of told you a bit more about that. The provider groups, the associations, so ONC, actually Dr. Rucker was at our town hall, so he traveled from there to here for our meetings as well. I think he spoke at WEDI as well, so I think he's been conferenced out this week as too. But the national associations, Sequoia project, we've already been helping try to do that to make sure the vendors are doing the right thing by doing the testing to enable that. But we also are working now with Carequality, and we're very encouraged with the support from this community. So a little bit about what is this thing that we're doing. So the image sharing implementation guide is actually a supplement. It's a supplement to the query-based document exchange guide. So what happened was RSNA helped fund somebody to write that. In the normal Carequality process, there's a work group that's spun up, and the vendor implementers come together, or the implementing organizations reach a consensus and write an implementation guide, and that takes usually a year, maybe more, depending. This kind of jump-started that. So what we did was we worked with RSNA, and we paid a technical writer, Steve Moore, who's been in charge of the radiology domain from day one, is actually a technical project manager for the Connectathons that are held for IHE internationally. He actually wrote the guide. We published it in the June timeframe, June during the SIM meeting, the Society for Informatics and Medicine. So basically, big SIM meeting, a lot of radiology-centered folks there, announced it in June, put it out for public comment for 3 months till September, received about 75 comments, and we've now folded those into the updated guide that was just published on Monday. And I'll be providing links to all that in the slides here in just a few minutes. But the American College of Radiology was behind this, SIM, as I mentioned, as well as RSNA. So we have 3 large, at least US-based organizations that's really behind helping push the existing work. So these are existing web service type standards that are considered final text in IHE, and they're actually pushing that forward. Now, some of the next steps we'll be doing is working with the steering committee here within Carequality, the advisory council, to formally adopt this. So this is still a draft guide. It's not finalized, but now that we have 3 early adopter implementers that I'll announce in a few minutes, we will work with those folks to tweak it and get it to something that they've decided that they all agree to, and then put it hopefully through the formal change management process to have it adopted really in first quarter, hopefully. At least that's the goal at this point, but we'll be keeping you posted as this rolls out. But really taking the existing work, trying to take and coordinate and collaborate and bring these things together. Now, these standards are already part of, I wanted to make this point, I know you can't read this in the back, but these are screenshots of the standards advisory. So the ONC Standards Advisory is published on a yearly basis, and these standards actually have been referenced, and it shows their maturity levels and whether there's tooling available and so forth. So there's 2 workflows within the Standards Advisory: inside the enterprise exchange of imaging, and outside, or the cross-enterprise from organization or gateway to gateway. So these are referenced as specs there, so I just wanted to kind of connect the dots. These are not anything that's custom for Carequality in general. Again, the implementation guide is really based on XCAI. I've mentioned that cross-enterprise community access for imaging is officially the name of it. There's some constraints that have been added. So the supplement is only 14 pages. And the query-based document exchange document, I think, is 85 or 90 pages. So what it's done is it's referencing back to just the specific policy sections or the standards, making the changes to each of the sections, but all the policy implications, all the purposes of use, all those things that are already understood as part of the framework are just referenced. So it's leveraging that. So it's a pretty low bar for entry. It's not a whole lot that folks have to do, and most of these imaging vendors have already baked this in their system. Probably 95% of the radiology vendors that have true production systems have this available. They've just not turned it up anywhere. This is the TechnoGeek diagram for it, for those techno-geeks in the room. This is the actual diagram of the workflow from the framework from IHE. The middle part of this piece right here is the XCAI. So it's imaging gateway. So it's an initiating gateway and a responding gateway. And it's just the transaction information to be able to exchange that back and forth. Now it is part of a bigger ecosystem known as the Cross-Enterprise Document Sharing, XDS. So we did not go into that piece. We didn't constrain anything past the gateway. So everything behind the gateway, that last mile, that's free reign. Now some of the PACS vendors and some of even the vendors I've talked to that are already adopters within Carequality have said, well, we want you to constrain more. You need to do more. Well, we wanted to start with this. I'm not going to say that there's not other opportunities for being able to standardize that last mile, but we don't want to really stymie, innovation either. So we want to try to take it with this step, but there is a possibility that there'll be some other, eventual constraints that folks think about from a, system-to-system interface. The systems that are affected by this really are those normal PACS systems, the RIS systems. EMRs are as well. I'm not saying that EMRs or EHRs are going to be able to take the DICOM package, but we're hoping that some of the metadata and some of the information that is available there would be something to at least show that this is available. Some of the innovation that I have seen in the customers of these organizations are you'll get a transcribed report from the radiologist and it'll have a hyperlink in it. And you'll click that link and it brings up that imaging systems portal or viewer. So it's kind of all integrated. It looks like it's all coming from the report. That's what we're really aiming for, is something that ties those things together but makes it so it can just bring that up. That's my goal, all right? That's what I'm going to keep preaching and helping move everybody toward. So I'm having those direct conversations with the vendors and saying, hey, how can we do this? And what do we need to make sure is in writing here to make sure that that's something that's a little bit more clear and helping everybody so that we don't have to do all this negotiation from organization to organization to decide, oh, well, I need to do it this way. No, I need you to do it here this way. Because sometimes even the same vendor systems will interface differently in different organizations and different implementations. So really we want to think about how we're going to take the DICOM image exchange and put it into practice. So the information here on the left side, on the left side of the slides, if they'll bring them back up, yeah, are really kind of an executive summary of the table of contents. So this is kind of what we've actually called out within the supplement itself. So those additional requirements that are in the bullet points at the very bottom are where we kind of further constrained or what that supplement really addresses. So how do we make it real today? We want to make sure that we leverage the RSNA image share testing program. I'm going to say that because if you have them test, then you know people can do it. The implementation guide right now is requiring or the supplement is requiring passing that testing just so that that's done up front. All the vendor implementers or the pioneers have all agreed we want to make sure we have like a baseline so we all know we are capable of doing what's expected so that we're not having to work those kinks out one-to-one once we go live on Carequality. They'll of course still do that production level peer-to-peer ping testing, but we're hoping that they're not going to figure out their issues doing that. They're going to do that up front. And I can say that all 3 organizations are in testing phase right now, and are going toward completion of that. So they're actually going through this process. So this slide actually shows the validation. So if you want to learn more about the testing program, there's a link here. And also the link to the query-based document exchange guide is this bottom. So it is actually published and posted. There was a blog that was written and we published under the Carequality blog. So if you go to carequality.org, the top part on the tabs that says blog, you'll see the announcement and the link, but I've given you kind of the cliff notes here so that you can actually go straight to the link and read more if you are interested, if it's something that's of interest to you. Now, this is something that the American College of Radiology was very behind, because they have an initiative they've been doing for a couple of years, led by Dr. Geraldine McGinty, and they have, kind of franchised the hashtag Ditch the Disc. So that's how we're kind of promoting this a little bit, because that kind of gets the idea of ditching the disc. That's exactly what we want to do, because really that's the only way that a patient or a provider can guarantee that they get a copy of what they need if they need that image. So we want to ditch the disc. That's the goal. So I wanted to at least introduce that to you. If you want to learn more about Ditch the Disc, there were 3 radiologists. There's a YouTube video that was filmed July, I think it was the 19th, and I've given you the hyperlink here, and you can listen to the 1-hour webinar. It's free. You just go, it's a YouTube video, just go straight to it and play that if you want to learn more about Ditch the Disc and what they're doing and why they're doing it. So hearing from actually 4 different radiologists. Dr. Mendelsohn was one of those. The town hall, this was kind of just giving you who was at the town hall. So on Monday when we launched this, these are actually a couple of the pictures that I snapped on my phone, so I was able to include them. So in this picture we have Dr. Mendelsohn, who is the chief investigator, helping from a clinical perspective, the guidance for all of this work. We actually had Dr. McGinty here, and this is Kurt Langlotz, who is on the board of directors from RSNA, and they actually kind of introduced and got behind kind of, this is why we're doing it, we're doing this together. We want to make and encourage everyone here to become a doctor, so we're really doing a call to action. All radiology vendors come to the table, start doing this. So we're trying to get more. So that's kind of what we did during the town hall. And I've just listed the folks that were there. Dave Castle drove over for it. So he was able to share a bit about Carequality. I wasn't able to take a picture for him because I was standing up there with him. But and then I introduced our actual implementers directly after that. These are our implementers, so I'm excited to say the first early pioneer adopters are Amber Health. They have a they partner with health information exchanges and EMR vendors. They're kind of a intermediary, is a good way. They have a VNA, a cloud-hosted option, and they do have a nice workflow that they integrate with many of their customers. So Amber Health, Life Image, also same kind of vendor, another intermediary. They have a lot of information exchange in different places. Dr. Mendelsohn actually has them as his image exchange cloud hosted organization, even though he has a different PACS. And then Philips came to the table as well, and Philips has technology to actually support not only the image exchange but also just the standard document exchange as well. So they actually have a gateway technology that can do document exchange and image exchange, and they're hoping to leverage it to do both. So these are the newest, well, maybe not the newest, there may have been somebody that came in after that, but they're the newest for now. Carequality Connected Agreement signees, so they've officially signed the CCA, and they are in process of, being an implementer. So however long that takes. Now, I do not have exact timelines for any of them. They've not been able to tell me I'm going to do this by September of 2020 or anything like that. But we're hoping to push them to get more of that information available by HIMSS timeframe. Maybe be able to announce a little bit more about the timelines for their implementation if they're willing willing to share those at that time. But I want to make sure to give them kudos because they stepped up and are really helping promote this and push this and have been good adopters. So they've been added to the larger implementer slide here. The ones above on the top of this slide are actually live networks that are in production today. The gray bottom side of the slide actually shows those newest implementers. So they'll continue to be there until they're promoted as a true production implementer. So the image share validation program, we're going to be asking them to test the one bundle. So there's actually 3 different bundles that we can test for. We do the XCAI initiating and responding gateway, but we also can test for the XDSI, which is the document source and consumer. And that's how you would want to make sure that that interaction could happen to support an EMR potentially, or at least some of the metadata for that. And then there's the registry and repository. I know that a lot of these vendors are asking questions about how are we going to do the patient matching, how are we going to locate the patient. So there'll probably be some innovation that they'll have to do with the record locator services and so forth. But all of that's spelled out in the query-based document exchange implementation guide today. So we're raising visibility to them. Here's the way that you're expected to do all of this. So the roadmap to really making this real is that if you're implementers, ask to figure out if it's something that's of interest, how can you integrate this new possibility in the future into your workflows. So, kind of putting a call to action to start thinking about how could you enable this with your organizations, how can this be leveraged to actually improve that care delivery within your region. We want to hopefully continue supporting the adoption of this final implementation guide and really start onboarding those customers from these different implementers. But there is also the talk of the future. I wouldn't be remiss to say something without saying something about FHIR here. But several of the comments we received are, what if we could do this piece using FHIR? There's a part called a key object service, a KOS package. Could we do this with FHIR instead? It's like, yeah, but where's it documented already? So we pushed back and said that the guide that we're publishing has to be web services based at this point because there are no FHIR implementations for real that are all over the place yet. So let's make sure if you want to move forward with FHIR, let's do that as a next step and think about how this could be something that as they're implementing, we can continue having them meet and talk as implementers with the fuller group of implementers to figure out what else we can do and where FHIR fits with the new FHIR implementation guide that Carequality is already working on. Where are the synergies? Where can we connect these dots as we need? So with that, I'm going to close with opening up for questions. If you do have questions and you're not able to talk to me today, send, of course, Carequality, anything related to that, to the admin account, anything around imaging in general. There is a group box that's actually sent to Dave, myself, and Dr. Mendelson and Chris Carr from RSNA. And then, of course, if you have anything testing related, send it to the testing email. So I'll let you quibble over who goes first.
I can start.
We're probably going to ask some of the same questions.
Okay, no problem.
Probably a number of the same questions, yeah. So we work across the street from each other.
Yes, and that's a good thing. And you're friendly.
We share a lot of patients. Those patients have a lot of images, and we're still disking, unfortunately. I think Stanford, Matt can clarify, has worked with a specific vendor and has decided what they're doing as an enterprise, but we're still kind of all over the place. So
Understood.
This is very exciting.
Good.
I would love to be able to use this to connect to Matt and other organizations in our area, most of whom are already on Carequality. Mm-hmm. But we are on Carequality through our EHR vendor.
Right.
And as you said, the EHR vendors aren't quite ready to wrap their arms around this. We talked about it over dinner last night, but it's not there yet. So for us as an organization, would we need to set up a second Carequality connection through our...
I'm going to punt over here.
Well, he couldn't answer me last night, so I thought I'd ask you.
I'm going to let him talk, because he's got a better answer than I do, I'm sure.
Yes, you would likely have to. So if you were to use Philips just by way of example, you would likely have a Philips directory entry that would have the imaging endpoints in that entry, and we'll figure out how to kind of make that work. But you would have to, assuming your EHR vendor was not ready to support you in this, and you wanted to move forward, you would have to find.
And would it
another
come
way
out
to
of
do so.
our
Who's your PACS
RIS,
vendor?
our PACS, or our VNA?
It'd be it could be the VNA or you can decide. If the VNA is going to give you enough information going far enough back in their cache that you would need all the time, that's going to be sufficient. I think that's, for instance, what Mount Sinai is going to be doing. But if you need to have, you'll still need to make sure the VNA has the ability to draw back those historical exams for when you do need them. But it depends on how your integration is. It could be
how it's
directly
been
from the
set up.
PACS or from the VNA. You decide what makes most sense for your providers.
The other thing that I'll mention, and we've certainly found this in our organization as we've implemented these systems, as we've integrated our imaging store, is that our radiologists are finding more and more interest in the EHR data. So you know, when they have the time, some of them will actually say, who is this that I'm seeing this picture of? And
Dr.
how-
Mendelsohn has Epic and his life image, and he uses both.
Yeah, so we do the same thing. And so it raises the question, you know, how is this going to impact radiologists' workflows besides being able to access more images? Are we going to see more folks sort of looking at that need for clinical data?
Absolutely, we're hoping for. That's what the radiologists, why all ACR and SIM, that's why they go behind it, because they also saw the need from their members of this helpful for their workflows.
I'm going to stand here while Matt talks.
Thanks, Didi. I'm Matt Eisenberg, Stanford Healthcare. So first question is a simple technical question about the DICOM package, which is one of my favorite phrases. You're not sending full DICOM. You're just
Yes.
sending you.
It will be the full DICOM
It's the
package.
whole shebang.
It's the whole shebang. That's
Okay.
what we're expecting at this point, yes.
So
that it
the
could be
900 slice, you know, MR, the whole shebang's
the
coming
whole
across.
shebang. Because think about it, what we want to enable for cancer, like if you're going, or like I'll use Tennessee as an example. We have Children's Hospital in East Tennessee, but we have St. Jude's in Western Tennessee. Sending the image, the whole package, so that they could actually take care of them in that other
So this
facility.
gets back to Stephen's point. And I love Dr. Langlotz. I see him every Monday when he's not at RSNA.
There you
He's-
go.
He's brilliant, and he has some splaining to do when he gets back to Stanford.
There you go.
So
You can corner him,
no, it's
and then
great.
he can call me when he needs help.
So the bottom line, as we were talking about before, is that there is the workflow that the radiologists want, and I love my radiologist colleagues, and there's the diagnostic quality, full DICOM package, share that with me. And then there's a whole bunch of decisions there about, do I need it short-term, long-term, stored or not stored,
Exactly.
yada, yada, yada. And that's what Kurt does, because I don't do that stuff.
Yeah, you delegate that.
But the rest of us don't want that. The rest of
Absolutely.
us want something much different. We want quick, non-diagnostic, help me make a decision, like you said, help me educate a patient, help me decide whether I need to go into the ED to see that fracture now or not. Totally different workflows. There's nobody looking at that through this.
That's not documented at all. That's something that could be in a future implementation guide.
Well, yeah, and I'll get out of my depth on some of the imaging things relatively quickly, but I would imagine that there are ways that you can have views into the full DICOM package that are not necessarily taking advantage of all the detail there that you could use for some of those non-diagnostic purposes, if you will. But ultimately, I think what we'd like to see is a very broad solution that would be able to encompass all the different types of images, I'll call them, including what we've sometimes referred to as the lighter weight images, along with full DICOM. We actually have a long history in the Carequality community of having a debate on this in two camps and actually not making any progress because we couldn't come to any general consensus on what we should prioritize. And actually, I think we had talked about this when you were chairing the advisory council. This was probably one of the topics. But with the RSNA being willing to sort of jumpstart the process a little bit with a specific focus on that radiologist need, that's largely where this is pointed at right now, which isn't to say that it can't expand into the future.
Yeah, no, Kurt and I have this
We're taking a baby
discussion.
step.
Yeah, no, this is great and incredible stuff. Kurt calls this image exchange.
Yeah.
When we do the non-diagnostic, we don't have the word for it.
No.
The image exchange light or skimmage exchange or skim image or who knows. But we're trying to figure that out.
But just think, we can actually improve that on a future phase.
No, absolutely.
I think it's something, it's encouraging that we'll start and then more people will want.
Right,
they'll
and
be able to
clearly
say
some
what
of
they
the
want.
EMR vendors are already getting there, so we'll figure that out. Yeah.
And two more questions, and then we
So
will need to
quick,
stop.
hey Didi, quick question sort of along the lines of Stephen and Matt, Dr. Eisenberg's questions. Is there thoughts, again, thinking ahead, such that the existing main workflow of pulling in a clinical summary document, CCD, might cross-reference some imaging items, so a hyperlink, if you will, in the CCD, so rather than having a separate information flow channel, that there's some cross-reference and then being able to pull in that skinny abstraction of an image or the full DICOM?
Technically, that can be done. We just need to document one agreed upon way of doing it. Today, that's happening, but it's being done different in every location.
Thanks.
Good morning. Question about that in-between workflow. You mentioned cardiology, and so in Nevada we are doing image exchange, proprietary vendor, the same vendor as New York is using. But there's a lot of requests for things like EKG traces, and that sort of falls in the, it's not a full-size DICOM, but it's larger
It's a different
than,
image.
yeah, it's still an image, and it doesn't really fall in the Carequality or CCD exchange because it's usually just a PDF. Is there some thought for those cardiology and sort of in-between images in this, and where does that lie between the Carequality and the Carequality image exchange?
Well, if it's in a PDF, that could be exchanged via the document exchange today. You know, put a CDA header around it, and that would be fair game for current document exchange.
The cardiology systems, it depends on, you know, most of them are also exchanging DICOM, so this is something that could be done using that DICOM package. But it is also something that the EKGs themselves are a different format, so it depends on who the vendor is. That's not part of the implementation right now, that's not in scope. But maybe because of this new, you know, image type of focus, we'll have more people coming to the table to see how that could be added. So all this could be added in frameworks in the future.
And really robust discussion, appreciate that. Unfortunately, we do need to get to our break, otherwise we're going to be behind and people will start to miss their flights. So, or we'll leave the meeting more likely, which we don't want either. So let's take a break until 10 o'clock and we'll reconvene.